So good afternoon, everyone. Welcome to this exciting debate, debating clinical and research needs in the NHS. My name is Neil Hudson-Basing. I'm the Corporate Events Manager at London South Bank University. I'm joined on screen by all of the people that you're going to be meeting during this lunchtime event. And you'll get to meet them all a little bit later. Before we do, I'd just like to take you through the Zoom functionality. So we're on Zoom webinar, which means that we cannot see or hear you, but you can communicate with us in various ways. So firstly, there's the chat box, and it's wonderful to see people making use of that already. Please continue to do so to share your thoughts, comments, and introductions. Let us know who you are, what you do, and where you're joining us from. We love to see them in the absence of seeing you face to face. You can also engage with us using the Q&A box, and we encourage you to reserve your questions for the Q&A box, letting us know who your question is for, and we'll dip into the Q&A box later. It saves us losing questions in the chat box. You can also upvote on the questions you most want answered by clicking the little thumbs up symbol, and that boosts them to the top, and we'll be working our way through those a little later. We'll have a poll as well, which we'll be launching at the start and close of the event to gauge your opinion on our big topic of the day. You'll see that we've enabled closed captioning, and that's the subtitles that you can see appearing on your screen right now. If you do not wish to see them, you can click on the little up arrow next to CC live transcript at the bottom of the screen, and you can choose to hide subtitles, but we do enable those in the interest of accessibility and inclusivity. We'd like you to share your thoughts and comments on Twitter as well as in the chat box. That helps us to ensure that the impact of this event goes way beyond just the event itself. And we'll be checking in with those later. Finally, I'd just like to remind you that whether in person or virtually, LSBU operates an environment built on equality, inclusion and acceptance, and believes everyone should be treated with respect, dignity and courtesy. Please keep the conversation kind and respectful. We reserve the right to remove anyone that isn't. I'd now like to hand over to my colleague, Dr. Suzanne Bench.
Hello, everybody, and a huge welcome to the second of the debates that we've been running at London South Bank University in the Institute of Health and Social Care as part of our pilot postdoctoral bridging scheme, which is funded by Health Education England London region. My name is Suzanne, as Neil said, and I'm a professor of critical care nursing, and I'm co-leading this scheme along with my colleague, Dr. Adele Stewart. And hi Adele, she's waving there. I also have a joint appointment with the Royal National Orthopaedic Hospital, where I'm the Deputy Director of Research for Nursing and an NIHR 70 at 70 senior nurse. So it's really exciting for me to see so many of you here today to debate what is an absolutely critical subject for all of us. And that's all I really want to say. Please do engage, please share. And I'm going to hand over to the chair for this afternoon, which is Dr. Eleanor Olgiati, and to wish all of our speakers good luck. And we're really looking forward to a lively debate. So over to you, Eleanor. Thank you.
Okay. Hopefully you can see my slide there. Thank you very much, Suzanne, and hi and welcome everyone joining us today for our second debate discussing contemporary issues in clinical academia. My name is Dr. Elena Olgiati. I'm a clinical psychologist working in the brain injury service at the Royal Hospital for Neurodisability in Putney, London, and honorary postdoctoral research fellow at Imperial College. So today we will discuss through a lively debate the following important question. Do clinical needs always take priority over research activity? We have a panel of speakers who are going to debate the following motion. The core business of NHS organizations is providing clinical care. Research activity is secondary to this. In our panel, making the case for the motion, we have Dr. Polly Livermore, Matron and NIHR GOSH BRC Clinical Academic Lead for Nurses and AHPs at Great Ormond Street Children's Hospital NHS Foundation Trust. And we also have Dr. James Harris, Senior Clinical Lecturer in Evidence-Based Midwifery at Chelsea and Westminster Hospital NHS Foundation Trust. Now, making the case against today's motion, we have Dr. Simon Riches, highly specialist clinical psychologist and academic tutor at the Institute of Psychiatry, Psychology and Neuroscience, King's College London, and the South London and Maudsley NHS Foundation Trust. And finally, Dr. Nolan Stein, Principal Clinical Scientist and Head of Cardiac Sciences at Bart's Heart Center. The structure for today's debate is the following. So I'm going to hand over to the panel soon, and everyone will have 6 minutes each to argue their case for or against the motion. And after this, I will open the floor for any questions you may have. As we were saying, please pop in your questions in the Q&A chat box at any time during the debate, and we will go through them at the end. As Neil was explaining before, you will also have the opportunity to click thumbs up to other people's questions if you also would like that question to be discussed by the panel. And the most popular questions will be prioritized in our discussion. After the question, each team for the motion and against the motion will have 2 more minutes for a final rebuttal, making their final case. And we would also like to start and end our session with a poll, which can add a little bit more perspective to our discussion. So we will have 1 poll now at the beginning and 1 at the end of the debate. So I'm now going to hand over to Neil for our first poll. Over to you.
Thank you, Elena. So our first opening poll, the core business of NHS organisations is providing clinical care. Research activity is secondary to this. Do you agree or disagree? So we're going to keep that open just for a moment. We can see you rapidly answering that, so keep those coming through. We are not going to launch the results of this poll until the end because we don't want to sway our closing poll. So keep those coming in and we'll keep a tab of when we've hit our full numbers. So we give another
I didn't realise
minute.
we couldn't vote as we were panelists, so I just tried to vote and couldn't.
There you go, we're almost at 100%, so we're at 85%. We'll just give it another half a minute, keep those coming through. So the core business of NHS organisations is providing clinical care. Research activity is secondary to this. So nearly there, to give you a few more seconds. We're at 88%. So if you haven't already, please do agree or disagree. 10 more seconds. There you go. We will call it there. Thank you very much.
Okay. Now, so as we were saying, we're going through the results from the poll at the end of the session. So I'm now ready to hand over to Polly, our first speaker, making the case for the motion that the core business of NHS organizations is providing clinical care and research activity is secondary to this. Over to you, Polly.
So thank you for that kind introduction, Eleanor. So I'm Polly, I'm a nurse by background. I was really fortunate to be awarded an NIHR Clinical Doctoral Research Fellowship, which I completed last year, and I've recently been awarded a Development and Skills Award with the NIHR. And both of those are to advance building my academic pathway, but I'm really thankful for this amazing opportunity to be part of this post-doc bridging scheme today. As a clinical nurse and as a matron who every day needs to keep beds open, I need to ensure I can safely staff them, and I am responsible for getting patients into the clinical areas. So I'm therefore supporting the motion for the core business of NHS organisations is providing clinical care and research activity is secondary to this. So before we begin, it's important to clearly clarify the terminology we're talking about today. So when we're talking about core business, we're talking direct patient clinical care. And when we're talking research activity, we're talking anything to do with research. So from research studies, research trials, and clinical research fellowships. So what is the evidence to support this notion? If I begin with this pivotal framework for all healthcare professionals, which clearly states that the core business of NHS organisations is providing clinical care. And as we know, the biggest threat to our capacity to deliver high quality care is shortage of resources. So let's look at resources in the health service in more detail. So the King's Fund, which was updated in 2020, tell us that NHS hospitals, mental health services and community providers report shortages of 84,000 full-time equivalent staff. 84,000 staff. So that's 38,000 of those are nursing vacancies. That's 1 in 10 posts. And we need to recruit at least 5,000 nurses a year from overseas to help. And there's many reviews that prove the link between low nurse staffing levels and higher rates of death, such as the Berwick report. So what guidance are our chief execs and our powers that be following when it comes to safe staffing? What are they told? Well, they're told that we need to employ the right staff with the right skills in the right place at the right time. And in this document, it specifies the essential aspects of the nursing role. And sadly, as you can see, there's no mention of research. So I'm hypothesizing that the majority of the audience are those interested in the specific focus of a clinical academic. So I thought I'd add a little of the evidence for you, or should I say, lack of it. So most nurses and allied health professionals are clinical academics, and we are older than academics outside the NHS. We are clinical experts first, and we become clinical academic researchers later. Our clinical research fellows outside medicine, we bring a clinical lens to our research, and we know that is essential to the NIHR. That's what they score us on our applications to give us fellowship funding. Our clinical expertise needs to be maintained or we lose our perspective. And research removes skilled, expert, senior practitioners from direct patient clinical care. So Clark and Linden set out to prove that there are better outcomes and more use of evidence by practitioners in trusts that are more research active through trial activity. But actually, they had to change their stance in view of their findings, reporting that consequences for patient health are uncertain and that there is no apparent evidence that patients treated by practitioners or in institutions that take part in research trials do worse than those treated elsewhere. So they couldn't prove they did any better. They actually had to stick with the stance that they couldn't prove they did any worse. What about Boas's study? And they conclude for us that there are too many confounders in organisational characteristics. So for example, in those trusts where more patients are in research studies, they also have a high volume of patients. So there is very limited evidence they conclude that engagement by clinicians and healthcare organisations in research improve healthcare performance. And what about the Jonker Papers, which I know my esteemed colleagues are sure to reach for? They cannot even provide unrefutable evidence because, as they say, most of the research which benefits clinical care is in interventional studies. And observational studies are not necessarily linked to improvements in patient care. And the observational studies, which are the ones that we're most likely to do as clinical academic research fellows, are not likely to reduce mortality or improve care quality. So to bring this back to the real world, I asked 100 Band 5 and Band 6 nurses in my trust last month the question at the very heart of today. Should clinical needs always take priority over research activity? And I'm sure it won't surprise you to hear that all 100 said yes. And as I'm a qualitative researcher, I couldn't resist adding for you some evidence for this. So as one said, if your child gets admitted to hospital unwell, you need clinical staff working on the wards to make them better. So finally, I take us back to the motion and I ask you, is there an active shortage of clinical staff in the NHS? Yes. Does this impact on patient outcomes? Yes. Is clinical care the most important activity for the NHS? Yes. I am not saying that research is not important, but for the motion I set out today, I ask you to vote that yes, the core business of NHS organisations is providing clinical care and research activity is secondary to this. Thank you.
Thank you, Polly, and very good timing as well. I'm now going to hand over to the first panelist arguing against today's motion, Simon. Over to you, Simon.
Thanks, Elena. Hi, everyone. My name is Simon Riches, and I will be arguing against the motion. In order to appreciate what this motion entails, I think we first need to consider what is the relationship between clinical care and research. What kind of relationship is this? One might see them as very separate activities where clinical care involves clinicians in hospitals or clinics caring for patients or service users, whereas research involves scientific researchers in labs or universities analysing data. However, their fundamental relationship is very different, and I will argue that one cannot draw a strict separation of clinical care from clinical research. They are not separable because clinical care would not exist without research. There is an inseparable and bidirectional relationship between clinical care and research, and therefore research cannot be secondary, and the motion is false. Instead, we believe it is more plausible to argue that clinical care and research are equally important for the healthcare system to function. A framework of evidence-based practice governs our clinical services. And this means an integration of best research evidence with clinical expertise and patient values. Clinical practice is the implementation of scientific research. Clinical practice is a result of studies, trials, systematic reviews, and meta-analyses of evidence that accumulate over many years. New treatments are and should be the products of research. So if we think about what clinical knowledge or clinical expertise actually is, it is scientific, research-based knowledge. But there is another important dimension that brings out the bidirectionality of the relationship between clinical care and research, and this is the practice-based evidence framework. Evidence drawn from clinician and patient experience will inform and feed back in to research in order to make our evidence-based practice more sophisticated, more nuanced, and more focused on patient-centered personalized care. So we need clinicians or clinical academics rather than just scientists to be involved in healthcare research, because their experience and approach is what makes this research most relevant to patients, to carers and clinical services. Healthcare research that diverges from healthcare services is no longer likely to be so applicable to those services. So if we want more evidence-based practice, we need more practice-based evidence. We need to keep improving treatments and improving patient experience. The twin concepts of evidence-based practice and practice-based evidence make it clear that without research, there would be no clinical care, no concept of best practice, no training, no treatments, no advancements in healthcare. It is vital that we have best practice and advancements in healthcare that improve practice. It is vital that we have standards of best practice from organisations such as NICE, and it is research grounded in services that sets these standards. So clinical care will suffer if research is considered secondary. Many healthcare professionals hold dual identities as clinicians and researchers. In some professions, this is known as a scientist practitioner model. But all clinicians should be implementing evidence-based practice. All should be scientist practitioners in this sense. Clinical decision-making needs to display a scientific style that foregrounds the evidence and logical methods of judgment. This is crucial when translating scientific concepts to patients. Informed consent could not exist without this. Clinicians need to be able to quote the risks, and without research, patients and the population would be uninformed. So clinicians need to embody a scientific style that they will develop by being research active. But what about healthcare emergencies? Situations where services are at capacity or overstretched. These will occur, as we have seen in the pandemic. In these circumstances, the healthcare service needs to adapt with greater focus from many clinicians on the immediate clinical response. But short-term firefighting is not sustainable, and longer-term planning will always need to be implemented. In the case of the pandemic, this has led to vaccines and treatments, and these are the products of research. Similar arguments can be applied to immediate problems such as staffing shortages and lack of funding. Long-term sustainable outcomes will need research embedded in clinical practice. So, in summary, I have argued that research and clinical care are of equal importance. Research and clinical care depend upon one another and inform one another, and that this is the best outcome for healthcare. And this is why we reject the motion that research is secondary. Thank you for listening.
And thank you so much, Simon. Just a reminder, if anyone has any questions, please pop them in the Q&A chat box as we speak, and we will come back to them later. I'm now going to hand over to the other panelist arguing for today's motion. James, good luck, James. Over to you.
Always a bad start when you wish luck when you're starting to speak. Hi everyone, my name is James, and I want to thank Simon for pointing out many really interesting points in this debate. I am going to do something slightly unusual and concede the vast majority of his points, because I agree with many of the things that he said, but I want to start by taking us back to the motion. The motion being that the core business of NHS organisations is providing clinical care, and research activity is secondary to this. Of course, research is important. We're not disputing that. We wouldn't be on this webinar if we didn't feel that. However, my position is that the core business of any NHS trust should be direct patient care. Simon pointed out the issues in regards to being research scientists, scientific practitioners. And I concede that point, that our regulating bodies recognise the importance of us being research aware for us to be able to provide the best level care to the service users that we serve. However, there is a difference between being research aware and research active. And my position is that to provide direct patient care, you need to be research aware, you need to know about the latest evidence in regard to shape your practice. But that doesn't necessarily mean you need to be involved in RCTs, doesn't necessarily mean you need to do thematic analysis of interviews. Instead, you need being research active is secondary to that, as it should be. My colleague Polly earlier on mentioned the staff shortages in the NHS, and I wanted to spend some more time discussing that. The vacancies within the NHS are spread across the whole of the country, with around 1 in 10 nursing positions currently vacant. This is spread across England, as I said, with the most acute problem being in London, as the graph at the bottom demonstrates. And this is, we have a wealth of evidence demonstrating that any shortages in staff result in negative impacts to patient care. It increases morbidity and mortality, and it decreases satisfaction in the services that people receive. Now, research obviously contributes to improving these outcomes, and we're not disputing that. But let's have a closer look at what research activity for nursing, midwifery, and allied health professionals looks like within NHS organisations. Tends to be that people that are research active within healthcare settings fall into 3 broad categories. So there's the people that work in research delivery, where they recruit participants for studies, they contribute to protocols, and they do an incredibly valuable job, but their primary focus is about collecting data for research studies that have been created by other primary investigators. There's another category of people, or for those who work for higher education institutions, so working in universities for a lot of their time, if not all of their time, both training the future generations of nurses, midwives and AHPs, as well as being research active. And there's a third group of clinical academics that provide, that work both clinically and work academically and on their own research projects as well. Now, there's around 4,000 research nurses working across England, and they do an invaluable job, as I've already said. But let's have a closer look at those working for universities. The data I'm presenting here is from the Council of Deans 2019 census, which was published in January 2020. And they demonstrated that of all of the individuals that work for universities across the country in faculties that teach nurses, midwives and AHPs, 94% of those individuals do not work clinically. Around 3% of nurses and midwives work clinically, and 2.5% of AHPs work clinically when they work for a university. This is despite the fact that around 26% of them are doctorate level trained conducting their own research. I'm not presenting a position that this is a problem. I'm just suggesting that there is a talent drain from NHS resources when research is seen as a greater priority to clinical care. This talent drain results in both a combination of a de-skilling and a decrease in confidence levels for these individuals. So if you're an individual that spends 37.5 hours a week working as a research nurse, but suddenly you need to flex up because of a crisis that Simon pointed out earlier, or if you're a university lecturer that hasn't provided direct clinical care for 5-10 years and suddenly are asked if you can go and help during a MAJAX, you're going to not feel completely comfortable doing that, completely understandably. And so it results in that shortfall of workforce as being a greater problem. And this was demonstrated acutely during the COVID response. So the NIHR suspended research activity truly simply because they recognised that direct clinical care during a global pandemic was the primary objective of the healthcare workforce and was the core business of the NHS. And I also want to point out that the two individuals pictured here, who are Professor Dame Sarah Gilbert and Dr. Catherine Green, who led the Oxford response to create the COVID vaccine, that neither of them are actually clinical academics. Sarah Gilbert is a vaccinologist and Catherine Green is a biologist. So the key part of our COVID response didn't necessarily come from clinicians. The motion of the core business of NHS organisations is providing clinical care, and research activity is secondary to this. My position is that during the pandemic, did research continue as previously? No. Were clinical academic fellows requested or felt obliged to return to their clinical duties? Yes. Therefore, it must be recognised that the core business of the NHS is clinical care, and research activity, whilst very, very important, is secondary to this. Thank you.
Thank you very much, James. And just a reminder to ask your question. Yeah. Okay. Just a reminder to please pop your question in the Q&A chat box and not in the other chat. Otherwise, it will get lost. Okay. Now Nolan will take it from here. Nolan is our last speaker for today, and he will make the case against the motion. Over to you, Nolan.
Thank you. My name is Nolan Stein, and I am arguing against the motion. Sorry, I just need to go back with my slide. Sorry, there was a slide freeze. We continue to argue that research is critical to delivering high quality care and should be integrated into it, as it is necessary.
We're not seeing your big slides. We're just seeing a preview.
Okay, I have shared them.
Sorry about that. Do you want to restart the sharing maybe?
Yeah, should I reshare it again?
Mm-hmm.
I have them if needs be, Nolan.
Yeah, if you could share them, that would be great. I think I'm having some IT challenges.
Thank you, Neil.
With me?
Great, thank you.
Hello. In the meantime, I'll just remind everyone to use the Q&A chat box so that we can use this as a starting point to discuss with our speakers shortly. Keep them coming. Thank you.
Thank you. So we continue to argue that research is critical to delivering high quality care and should be integrated into it to achieve core business objectives. Although my opposing team has highlighted some evidence which may question the value of research in core business delivery, we will present other evidence that notes the importance that research is a critical part of core business delivery and delivering excellent clinical care. This is because it has shown to improve patient outcomes, promote a positive experience, drive up quality standards, boost staff confidence, and support staff development. Next slide, please. Research improves patient outcomes. Several studies have noted engagement in research leads to better outcomes, most notably in mortality indicators. Often research active trusts have greater investment in staffing and infrastructure, greater cross-functional team workings, and foster implementation of emerging practices, all which are linked to better overall trust performance and improved patient outcomes. As the opposing team has highlighted, these positive trends are more noticeable in interventional studies opposed to observational studies in some research. However, other studies have found the same association more generally. Next slide, please. Research raises quality and standards. Organizational quality and standards are central to core business and delivering excellent clinical care, and research has a significant role. In research active organizations, there is an association between research and higher CQC ratings, fewer never events, avoidable infections, improved patient experience, and staff feedback. These higher rates apply to research done within the community and in the acute setting. It is thought that the reason for this is that there is better staff engagement, staff training, staff satisfaction, all which are linked to overall trust performance, which has a key role in driving up standards. Next slide, please. Patients have a positive experience when conducting research. A recent patient experience survey done by the NIHR has confirmed this. Over 90% of patients said they would partake in research again, and 90% felt valued. Other studies have shown that in research active organizations, there is more confidence in the health professions treating them because they have a greater understanding of the treatments they are using. Next slide, please. Flowing from this, research has noted boost staff confidence. In a study done by Jonker, they did a staff survey to assess the impact of research on staff, and they showed a higher correlation between research active institutions and staff confidence as a result. And they identified 4 key areas: good learning habits, promotes team working, increased staff knowledge and treatment, as well as best practice and best evidence. And these collectively made staff feel more confident in their practice. Next slide, please. Research creates opportunities for professional development. Nowadays, trusts are looking for ways to support clinical academic careers, not just for medics, but also allied health professionals, nursing, and healthcare scientists. BARTS is one trust that has published a mode to create a sustainable infrastructure to enable postdoctoral health professionals to continue research as part of their core job plans. And the ultimate goal of this is to have a strong postdoctoral research, not only to implement research, but to generate new knowledge and research for the benefits of patients. Next slide, please. The importance of research has been recognized as a national level, and a recent document in March 2020, Post-Pandemic Surges, highlights the importance of embedding research in clinical practice. It has also highlighted the importance of research, which was central to the pandemic response, as both my colleagues have highlighted previously. It built on previous works in the NHS, which set out a 12-point plan to support the embedding of research in clinical practice. And indeed, the NHS long-term plan, which is the future blueprint of how services being delivered, highlights the importance of embedding research in clinical practice and the critical role research will play in evaluating the outcomes of this highly ambitious plan. Next slide, please. In summary, does research improve patient outcomes? Yes. Does research raise quality standards? Yes. Does research improve the patient experience? Yes. Can research lead to better investment in services and infrastructure? Yes. And are all these factors central to excellent clinical care and core business delivery of the NHS? Yes. And thus the case is made. Thank you.
Thank you, Nolan. Very good points made on both sides today. Now, I'm now happy to open the floor for questions from the audience. So at the moment, the most voted question is, as non-medical AHPs, we have a problem in our career structure that take us away from clinical care if we want to undertake research, unlike our medical colleagues. There are just not enough opportunities for joint appointments across NHS and universities. How can we improve this picture? Does anyone have any thoughts? So it looks like this person is supporting the team against the motion.
I can have a go at answering that question.
Okay.
I'm a midwife, and I'm a clinical academic midwife with, not with a joint appointment, but with an appointment by an NHS trust. And my contract is to work 2 days a week clinically and 3 days a week on my own research. These jobs do exist, but they exist, but they do require us to carve out and forge our own careers. And I appreciate that's not easy. I completely recognise the disparity that we have compared to our medical colleagues, where they are expected to do research and work for the NHS and have contracts with the universities, and it is very easy for them to progress. But we are at the vanguard, forging change within an old organisation. And I would suggest, if you make the case to chief nurses, if you make the case to chief allied health professionals, and demonstrate the value that we can offer as clinical academics, these posts will be created. And if you look at NHS jobs, they're being created more and more every day. So just keep your eye out and apply for them.
Just to add to that, I think in terms of our arguments, you know, we're arguing for the equal importance, the mutual dependence between clinical practice and research, but we very much recognise that the reality is that research and clinical practice are not always well integrated. I think often it can feel to many people that they're not well integrated at all. And certainly that's something I think people can feel in their careers. So I sort of recognise where that question is coming from. I think it's a problem. I think certainly it's something that can feel frustrating for people who work in healthcare and want to pursue a clinical academic career.
Okay, thank you very much. Moving on to the next question. The next most voted one is from Donna. She's wondering, are clinical audit, service evaluation, quality improvement considered research activity? How can we measure and improve care without these activities? Any thoughts from the panel?
I can say one thing on that. I think there's a technical sense in which they would be classified differently from research, but I think from the perspective of our argument, what we're particularly in is this sort of broad category of the evaluation of the interventions. Our argument is that it's important that interventions, treatments are evaluated, and that there are standards that are set and that we aim to develop and improve. And I think for me that would fall under a general category of evaluation, which would include research, but it would also include service evaluation, audit, quality improvement projects, and so on. And I think central to our point is that evaluation should be embedded in clinical practice. It should be, clinicians should be involved in it, not merely aware of it.
And I completely agree. I mean, the only counter argument I would give, or the counter position, it's not even an argument, is that in a period of acute crisis, and I'm not just talking about the pandemic. So in October, maternity units across London attempted to close 196 times. That's all of the maternity units in London. That works on average something like 6 attempts to close each day. An attempt to close means that we don't accept any new patients and new service users into the service. So if someone is labouring that's booked to come to a particular hospital, we try to direct them to a neighbouring trust. Of those attempts to closure, only 6% of them were successful because of other hospitals weren't able to take the women that were labouring. Now, if during that time period, someone was conducting an audit or a service evaluation, I, as one of the leaders of the service, would have been extremely frustrated, because of there were women that were having babies with no midwives to care for them. And so this is, I know lots of the talk in the chat is talking about pandemic and it's a unique situation, and I'm not disputing that, but the pandemic isn't what impacted our issues. And what's happened is an acute underfunding of the NHS and acute gaps in our workforce. And yes, sorry, I'm going to start ranting, so I'll stop there. But yeah, I think it's the issue is acute at the moment, is all I'd say.
Thank you, Simon and James. Moving on to another question. So we have a question from Caroline. How can we encourage trusts to enable us to take part in research, which is vital for patient care, when we are already struggling to undertake clinical care? I find that much of my involvement in research needs to be done in my own time. There's not enough time in the job plan to complete the clinical work needed. I agree, though, that research is vital and would feel it is better for patient care. Although I recognize that the evidence presented by Polly at the start of the meeting doesn't really support that.
I would take this one, Elena, and I completely agree with Caroline, I really do, and that's what our argument was about today. As a matron who every day comes into work, and my job, whether I agree with it or not, is to staff the wards. And I have to ensure that I have enough nurses on the ground, I have enough beds open, and I'm able to get my patients in so that they can get to theatre and have their treatment and get home on time. So I do agree that there is not enough time, especially for clinical academics, to be taking part in our research. And a lot of it takes part in our own time, which is weekends and evenings, which is unrecognised, I feel, by most of the trusts from my postdoc fellows that I've been speaking to over the last year. So I do clearly agree. And I think only from the voice from the majority of the people and from the evidence that we publish from our dissemination events can we actually really clearly show that our research is benefiting patient care and is just as important as clinical care. Although clearly, I believe it is not seen as that at the current moment in time, which is what our argument was about.
Any other thoughts from the speakers, or shall I move to our final question? Shall I move on? Yeah. Okay, so due to time, I think we have time for just one final question from Jackie. If research is not to happen in the NHS, what's the alternative? So what alternative framework would you propose to continue research activity for clinical academic? Anyone want to tackle this one?
I would say I don't think any of the panelists are arguing that research activity shouldn't happen in the NHS and shouldn't be done by clinical academics. I think the arguments that we've tried to present is what should the primary focus of NHS care be? Should research be fully integrated into clinical care so that it is every day everyone's bread and butter and the whole service is bread and butter? Or should the needs of the service users that we are there to treat always take precedence over other activities, and not just research, but also exploring the menu options and exploring the decoration of the walls and the various different other things that the NHS does that's very important and vital to improving the outcomes of people. But what the debate today that we're discussing is the primary focus of the NHS direct clinical care or not? And is research secondary to that, or is it just as primary a focus or not? So I don't think that we should have an alternative framework. I think that clinical academic careers are very important, but yeah, I don't know if I've answered the question. Simon, you're on mute.
Apologies, I should know that by now. I was just saying that I think that's very helpful as a way of characterizing the debate. But I think our argument is just slightly different from what James presents, in the sense that we're not arguing that research is primary. We're not arguing that the clinical practice is primary. We're arguing for a combination of the two. They work in tandem with one another. And it's from that we draw the conclusion that research can't be secondary. We see a more fluid process, and that's what we're presenting.
And I think just to redirect from that, and I think research does need to be integrated and run in parallel to it. And there are many examples in healthcare where research is a critical part. If you think of cancer, for example, there's large parts of salvage therapy where it's the patient's last hope. And if there wasn't research running in parallel, it would have quite a negative impact on patient outcomes.
Thank you, everyone. We now have to close the Q&A session for today due to time. Thanks to our speakers and to everyone who contributed to such interesting discussion. It's been really interesting to hear from the two sides. Very, very good points have been made. There is now one final opportunity before we vote again for the teams to summarize and make their case. So now I'm going to hand over to the two teams, and each will have 2 minutes for their final rebuttal. So last few words to make the case for or against the motion. The first team is the team for the motion. So that the core business of NHS organization is providing clinical care and research activity is secondary to this. Over to you, James.
Thank you. And again, thank you for a really interesting discussion on where I've learned a lot, and thank you for everyone's really interesting questions. The position that Polly and I have been making is that research is incredibly important, and that having that within an NHS setting is incredibly important. However, the primary focus for the NHS service providers should be direct clinical care. And the evidence that we have for this is in multitude. We can use the example of the pandemic, but we can also use the example of curriculums for example, nursing education, where a lot of nursing degrees don't have a research module anymore because it's seen as taking time away from learning the skills that nurses need to know before they can qualify. And there's a variety of pressures within the workforce at the moment, which is resulting in an increase in morbidity and mortality and a decrease in satisfaction for people that use the NHS. And we need to focus on this. We need to get investment back, and we need to improve the outcomes of the people we're here to serve. And now I rest our case.
Okay, thank you, James. Now the team against the motion that the core business of NHS organization is providing clinical care and a research activity is secondary to this. Over to you, Simon.
Thanks, Elena. I'd also like to thank everyone for their questions and also my fellow panelists. So we've argued that research and clinical care are equally important and mutually dependent. And we've argued that research improves outcomes and experience for patients and raises quality standards. We don't deny that the NHS faces enormous clinical challenges. We recognise there'll be times when clinical practice becomes a primary focus, but this as a short-term approach is unsustainable to address the wider healthcare needs. And we need research for long-term sustainability and development. Indeed, a short-term focus on clinical practice is only possible because of the existence of evidence-based interventions from research. And we also recognise that there are certain research designs by definition that will have a greater impact. We're clearly more likely to see direct impact from intervention studies by definition. This does not diminish observational studies. They have different aims and provide important contextual information, but it's all these kinds of studies collectively that help us to better understand healthcare problems and improve treatments. And the thing that I really want to emphasize is that it's central to our argument that research should be grounded in clinical practice to make it most relevant. Healthcare research must involve patients, it must involve carers, and it must involve clinicians. It should not be conducted independently of its stakeholders. And so clinicians should be involved in research and not merely research aware. We recognise that research is not always well integrated with clinical care, but we argue that it should be. And that's why we believe that research and clinical care are of equal importance. Research is not secondary, so we believe you should vote with us and against the motion.
Fantastic. Thank you to both teams. I'm now very curious to know whether the speakers have managed to sway the audience opinion with their final rebuttal and with the Q&A session. I'm going to hand over to Neil to relaunch the poll to see where we are. Over to you, Neil.
Oh, let's launch that closing poll. So there it is. And there, just to relay the question again, the core business of NHS organisations is providing clinical care. Research activity is secondary to this. Do you agree or disagree? And we'll just keep that going for a few moments, and then I'll release the results of this one and we'll compare it to our opening poll results. So those are rapidly coming through. Already at 82% of attendees have answered. So we give it another half a minute. So the core business of NHS organisations is providing clinical care. Research activity is secondary to this. 90%. 10 more seconds. We've got some great comments coming through for our panel. Excellent debate, thank you. We'll keep those going as well. Let's end that poll there. We're at 90, almost at 95%. So we will end the poll. So I'm going to share the results. So these are the results of the closing poll. So we do have a sway. So our closing poll is 35% agree and 65% disagree. For our opening poll, 47% agreed and 53% disagreed. So there has been a sway as to disagree. Thank you very much, everyone, for voting.
Yeah, interesting. A huge congratulations to both sides. Interesting to see that the two sides were really close at the beginning, but then throughout the debate, the team against the motion managed to sway the audience opinion. Yeah, well done, everyone. It was a tough one. Some food for thought. Okay, so I'd like to conclude the session, the debate, thanking again our fantastic panel of speakers for such great arguments today. And just a final point from me, the panel's opinion may not have been their personal opinion. They really prepared for this academic debate and they worked as a team to explore arguments for and against the motion. So well done. Thank you, Polly, James, Simon and Nolan. And thank you, Neil, obviously from LSBU for making this event possible. Thank you to our audience who engaged with the debate so well. This debate has been recorded and a link will be shared. And if you like, you can continue this conversation using the hashtag on Twitter, LSBU Fellows 21. Thank you, everyone. Thanks again.
Lots of great comments coming through, so I'll keep that going for a few minutes. But any closing words from Adele or Suzanne?
Yes, thank you. Just on behalf of Suzanne and myself, congratulations to all the fellows who presented this afternoon. Well done. We're very proud of you. And to all of those who are part of your cohort who were listening in, you have all done exceptionally well, and what a wonderful opportunity to share those with colleagues out in clinical practice. So well done, everyone. Thank you, Neil.
And can I just do a little plug that this was a pilot postdoctoral bridging scheme that is coming to an end. LSBU, in collaboration with King's, have won the contract for the next 3 years to run this scheme, and applications for the next postdoctoral bridging scheme will be opening on the 1st of December, and we have a webinar on the 10th of December to introduce the scheme and to have a Q&A, so do look out for that, and we hope we'll see many more of you debating sort of contemporary topics in this space soon. So thank you very much.